advanced cardiac arrest. Advanced cardiac arrest algorithm. So this is the topic. So to start off with questions, what is the initial step that has to be done? Initial step in the advanced cardiac algorithm. Next is, in case of VF or a PVT, what are the sequences we need to follow? Next question, in case of the asystole or the PEA, what are the protocols that has to be followed? So we'll find out these answers in this video. So first, in case a patient has a cardiac arrest, the first thing is to start the CPR. And next one is to administer the oxygen. Next, we need to attach. We attach the defibrillator. So after doing this, we expect or we can look for the rhythm. So the rhythm, it can either be yes, it is shockable, or no, it is non-shockable. So in case the rhythm is yes, it is shockable. So this refers to the ventricular fibrillation, that is the VFib. Or in case it is pulseless, it is pulseless ventricular fibrillation, that is nothing but the PVT. Next case, we look at no, it is the rhythm is non-shockable. So in this case, it refers to the there is asystole as well as the pulseless electric activity, that is PEA. So now we are going to dive in detail. So in case of there is VF or the PVT, so how does it proceed? So the first step is we have to defibrillate, defib, then we immediately resume the CPR, that is for 2 minutes. Even if the defibrillation has worked, we give immediately resume CPR for 2 minutes. And next step is to give the IV as well as the intraosseous access. Then we look for the ROSC. And in case the ROSC, that is a spontaneous circulation return. So here we look for the ROSC. So here if it is yes, there is a return. Then what we do is the post-cardiac arrest. So we do the post-cardiac arrest care. Next, in case the rhythm shockable is, if it is no, then we look for the rhythm is shockable or not. So we check for the rhythm. Is it shockable or not? So in case the rhythm is non-shockable, so if the answer is no, then there is a management of the asystole. So we manage the asystole or the PEA. So in case this rhythm is shockable. So if the answer is yes, this rhythm is shockable. So next, what do we do? So here, if the rhythm is shockable, we do a defib, that is defib plus the CPR. This is done for 2 minutes. And then we also add the epinephrine. There is addition of the epinephrine. So the epinephrine is 1 mg, which is given every 3 to 5 minutes. And along with this, what we consider is the ET intubation. Next, we again look for the ROSC, that is return of the circulation, spontaneous circulation. So here, in case the answer is yes, there is a return of the spontaneous circulation. So what we do is post cardiac arrest care. So we put the patient in post cardiac arrest care. Then we move on to the ROSC. So in case the ROSC is, the answer is no. There is no return of the spontaneous circulation. So what we do is, we again check if the rhythm is shockable. So in case the rhythm is, the answer is no, it is not shockable. Then we again return back to the same, that is the management of the asystole or the PEA. Next, we check if the rhythm is shockable. So we saw if it is non-shockable. So now we look for the rhythm being shockable. So we say, in case yes, the rhythm is shockable. So here what we do is, we again do a defib and we do a CPR for 2 minutes. Then we add the amiodarone, or there is the lidocaine which can be used. Then what we do is, we treat the reversible causes. Treat the reversible cause. Next, we look for the ROSC. So here the answer, in case yes, then we put the patient in the post cardiac area care, post cardiac arrest care. And in case the ROSC is no, so again we go back from where we started, that is the rhythm shockable or not, and we check again. Next, we move on to the other scenario in case of the asystole. In case there is a condition of asystole or the PEA. So here we administer the IV or the intraosseous, access along with the epinephrine, and this is ASAP, that is as soon as possible, and continue it 1 mg. So the dosage is very important. So we need to continue with, that is 1 mg for every 3 to 5 minutes, and along with that we give a CPR, that is for 2 minutes, and along with the ET intubation. So after this we look for the ROSC. So in case the answer is yes, we have to go for the PCAC, that is the post cardiac arrest care, and in case the answer is no, so in such a case we check if the ROSC, that is the rhythm, is shockable or not. So in case the answer is yes, it is shockable. So yes, it is shockable. And then what we do is management of the VF or the PVT. Next, we look for the answer being no. So in case the answer turns out to be no, it is not shockable. So what we do is we check for the CPR again. So the CPR is done for 2 minutes along with the treating the reversible cause. So when this process is done, so after this process, we look for the ROSC. So the ROSC is done. So here again we go back to yes. So in case it is yes, it is nothing but the post cardiac arrest care, that is a PCAC, that is a post cardiac arrest care. And in case the answer turns out to be no, so it is non-shockable. So what we see is, in case the answer is no, we check if the rhythm is shockable or not. So in case of non-shockable, the answer being no, we jump into the initial step where we saw the administration of the, there is a IV or the intraosseous access along with the epinephrine ASAP and continue 1 mg every 3 to 5 minutes along with the CPR for 2 minutes and with the ET intubation. So this process, this step, we go back to this step, and in case the rhythm, it turns out to be shockable. Yes, it is shockable. So in such a case, what we do is we manage for the VF and the PVT. So now, just to answer our questions. So the first question we asked was, how do you treat the advanced cardiac arrest? The first step. So the first step is nothing but to start the CPR. So in another video, we saw what is the effective method to give a CPR. So here we do that with the effective method of CPR, and then we administered the O2 along with the attaching the defib. So here then we look for the rhythm being it is shockable or not. So we check for the rhythm shock. So is it shockable or not? So in case it is shockable, the answer being yes, it is shockable. So then what we do is the VF, ventricular fibrillation, and the PVT, that is tachycardia. So then we look at the answer being no. So the scenario being no, it refers to the asystole, as well as the PEA, that is a pulseless electric activity. Then we move on to the next question, that is what happens in a case of VF or PVT. So how do we manage? So to quickly run through, the first one we saw was we defibrillate, and along with a CPR is given, that is 2 minutes, and along with the intravenous or intraosseous access. And then the important point being, we checked for the ROSC. So what we saw was the ROSC was checked, and in case yes, so wherever we do ROSC, we need to check if it is yes or no. So wherever it is yes, it automatically it refers to the PCAC, that is nothing but the post cardiac arrest care. So wherever it is positive, it goes to the post cardiac arrest care. So then we look for the ROSC being no, there is no return of the spontaneous circulation. So in such a case, what we do is we check if the rhythm is shockable. So this is also the same. So wherever the ROSC is no, there is always we check for the rhythm being shockable or not. So in case the rhythm is non-shockable, we manage for the asystole or the PEA. So in case yes, the ROSC is shockable. So it is shockable. So what we do is again we defib. The defib, CPR, as well as the epinephrine. So this epinephrine is given 1 mg every 3 to 5 minutes. And along with this, we had to consider the ET intubation. Next, we look for the again. So after this step of management, that is defib, CPR, and epinephrine, that is 1 mg every 3 to 5 minutes, as well as considering the ET tubation. So then we look for the ROSC. So in case of the ROSC, the answer, in case if it is yes, we saw we have to do the PCAC, and in case if it is no, we again look for the rhythm being shockable or not. So rhythm, in case if it is no, we go for the other algorithm, that is the management of the asystole as well as the PEA. So here the rhythm being shockable. So yes, it is shockable. So then we again do another set, that is we do a defib, we do a CPR, that is for 2 minutes, and then we add on to the amiodarone. There is addition of the amiodarone, or the lidocaine. So we give the amiodarone or the lidocaine, and what we do is we treat the reversible causes, reversible cause. So this step is done. And lastly, we again check for the ROSC, return of the spontaneous circulation. So in case the answer is yes, what we have to do is the PCAC, that is post cardiac arrest care. And in case the answer is no, what we have to do is we again go back to the first step, that is we check for the rhythm being shockable or not. So this was in case of the VF or the PVT. So next we are going to jump to the last question we asked. The last question we asked was in case of the ersystole. So in case of the ersystole or the PEA, what is the algorithm? So the first thing we do is we give the IV, intravenous as well as the intraosseous, assess, and along with this what we do is we do the epinephrine ASAP, that is epinephrine very quickly, and continue 1 mg for every 3 to 5 minutes, and along with this we do the CPR, and this is for 2 minutes along with the ET tubation. Next thing we do is we look for the ROSC. So in case of the ROSC being yes, so as we know, wherever the ROSC is yes, what we do is the PCAC, that is nothing but the post cardiac arrest care, and it being no, so the ROSC being no, what we again check for is the rhythm being shockable or not. So is the rhythm being shockable or not? So in case the answer is yes, the rhythm is shockable, so we go on to the other algorithm, that is management of the VF or the PVT. Then we look at the rhythm shockable. If it is the answer is no, the rhythm is not shockable. So rhythm being no, it is not shockable. So in case of the rhythm being non-shockable, what we do is we again look for the CPR, that is for 2 minutes, and we treat the reversible causes. And after treating the reversible cause, we again look for the ROSC, and if it is yes, we give the post cardiac arrest care, and in case the answer is no. So here what we do is we again check for the rhythm being shockable or not. In case the rhythm is shockable, the answer is yes, what we do is we go for the management of the VF or the PVT. And in case the rhythm is no, then what we do is we jump onto the initial step, that is the IV or the intraosseous access, and then the epinephrine is given ASAP, and along with it we have to continue 1 mg for every 3 to 5 minutes. And along with this what we do is we give the CPR for 2 minutes and also the ET tubation.